My husband and I were on an airboating trip in Central Florida, and through a friend of a friend, found out about a litter of black-mouth cur puppies. Went to see them. There was 8 of them, all in a bundle. We got down on one knee to play with them, and Carolina was actually the runt of the litter and came right up to me, curled up in between my legs, and really fell asleep. So we went home with the dog that day, not intending to, but she absolutely chose us. So I have a nautical background. My husband has a nautical background. We've been around boats all our lives, so we actually had a Carolina skiff at the time, and so we named her after our Carolina skiff. And her middle name is Cypress, as an homage to Central Florida, where we were airboating when we got her. She is a very active dog, and she has been her whole life. So she just turned 6 now. We have always been very active with her out on the boat, on the golf cart, on road trips. So she goes to Michigan with us every year to visit my family. And last summer, when we were up in Michigan, we would go on 2 and 3 walks a day for about 5 or 6 miles. And she just started urinating really frequently. And we thought initially that it might be a UTI, but it wasn't very consistent. And she didn't have any other symptoms. So we were just monitoring it for a couple weeks. When we got home after the Michigan trip, it hadn't improved any. So we went to our primary vet, and they did a culture at the time, put us on antibiotics for a perceived UTI. We came back after 2 weeks because she still was having the frequent urination symptoms. And at that point, they did a quick ultrasound at the veterinarian and informed us that she had a tumor in her bladder.
So Carolina was diagnosed with bladder cancer. The hard thing in our canine patients is that they can't tell us that, they feel pressure in their bladder or they feel funny. So a lot of times when our patients are diagnosed with bladder cancer, it's a more advanced stage. So the tumor has grown large and they're already having symptoms that are visible to the clients. For example, with Carolina, the veterinarian, the general practitioner did an ultrasound and found a bladder mass when they did the ultrasound, and that's when Carolina was referred to us.
My husband's cousins are both veterinarians, so we consulted with them a lot on what their recommendations might be. And their recommendation was a doctor that's here at the practice. So this is where we decided to bring her for really that kind of second opinion with an oncologist on what we were going to be dealing with.
Carolina's treatment was unique in the sense that she received radiation therapy for her bladder tumor. She had cancer nowhere else in her body. It was localized to the bladder. When a patient has localized cancer, we are usually looking at some sort of targeted therapy. So since surgery was out, radiation therapy became a really good option for her because we could target the tumor with this beam of radiation and kind of shrink that tumor, or at least stunt the growth of the tumor. And so that's what we chose to do for Carolina. Carolina is just this happy dog. Like, she loved to come to the clinic. She would wag her tail, very social. So to put her through 20 fractions of radiation was not a concern because she was sort of that outgoing, sort of social dog that actually loved to come into the clinic.
So radiation oncology involves using X-rays to target cancer cells to try to kill them while sparing the normal cells and allowing those to live their natural life. Carolina had a bladder tumor, and when we treat bladder tumors, the local treatment, since we cannot usually surgically take them out, is to use radiation or X-rays to kill the cancer that's there. And so for her, she got a month of radiation, Monday through Friday, where she got small doses of X-rays every day just to the bladder and the surrounding urinary tract. And that was to target the bladder cancer, and it led to a great result. So this is the linear accelerator, the machine that generates radiation to treat the cancers. When the animals come in here, they're usually under anesthesia, and that allows us to treat them while they are completely still for 2 to 6 minutes. That's how long the treatment takes about.
Meeting with a cancer specialist absolutely gave us hope that we still have years with her. Being able to talk to a cancer specialist and know that there are treatments out there and options out there that can, prolong that was incredibly, that's really what kind of turned us around on being able to cope with it and process it.
Carolina is really asymptomatic for her disease. She is kind of living her best life, right? Which is what we want for our patients. She is a normal dog. She goes about the normal routines of her day. And what we expect with the radiation therapy is kind of that we stunt the cancer and we stop it from growing, because the definition of cancer is unrestrained cell growth. So if we can stop that cell growth, then we have met our expectations. We were able to shrink her tumor by about 50% with the radiation therapy, and now that tumor is remaining stable. I would say that Carolina, at this point, her prognosis is very good for continued months to maybe years of good quality life.
So I think doing your own education and your own research, so you can kind of take the time to understand, but absolutely trying to find a cancer specialist near you to be able to go and talk to and get that second opinion, I think is critical, because it can seem doom and gloom otherwise.
So we are able to kind of break down everything for the client and kind of lay it out so it makes sense. And then we're able to walk that client and patient through the treatment. So although it seems scary, I think that coming to at least hear what the options are is so valuable to a client, because then they know what's out there.
Good evening, everybody, and welcome. For those of you that were on a little early, I hope you enjoyed the video. It was fun for us to make. So welcome to the 2023 Animal Cancer Care Clinic Summer Webinar Series, How to Navigate Through the Cancer Diagnosis. I'm Dr. Stephanie Correa. I am the founder and president and owner and oncologist and dog holder and primary problem solver for Animal Cancer Care Clinic. It's hard to believe that this is our third year holding these sessions. So thank you for your participation. Thank you for your support. That is what makes these events possible. The webinar series is also possible because of the generous support that we are once again receiving from Merck Animal Health, the sponsor for our entire summer webinar series. So thank you to the professional team behind the scenes that's here kind of helping all of us, Dr. Sones and I, to present tonight. And before I introduce our presenter, Dr. Evan Sones, I'd like to express once again how grateful I am for the support that ACC receives from the primary care veterinarians throughout the state of Florida. And every time I do one of these webinar sessions or I go to a meeting, I am again reminded of how valuable this community of veterinarians is throughout our state, and how much I appreciate the camaraderie and community of veterinarians, especially as I become more and more seasoned in my profession. So a few quick notes and then we'll get started. Please remember that we are easily able to process your referrals by using our Cancer Care Referral portal. That's at cancercarereferral.com. And if you stay for the duration of the presentation tonight, you will receive your CE certificate tomorrow by email. And then at the end of the session, Dr. Sones and I will be answering questions. So please go ahead and type your questions into the chat box. So now, Dr. Sones. Dr. Sones is a veterinary medical oncologist who grew up in the state of Louisiana. Dr. Sones visited Florida many times during his childhood and is now allowed to feed his obsession with Disney World by living in Orlando. And Dr. Sones' house almost backs up to the Magic Kingdom so he can watch the fireworks there every night. So Dr. Soanes received his bachelor's degree in Doctor of Veterinary Medicine from Louisiana State University. He then completed an internship at Georgia Veterinary Specialists in Atlanta before completing a medical oncology residency while earning a master's degree in biomedical sciences at Auburn University. Dr. Soanes, a board-certified medical oncologist, joined ACC in 2012, and he sees patients in our Central Florida locations. I am very pleased to present my good friend and colleague, Dr. Evan Soanes.
Hi, thank you for that introduction. Well, thanks everybody for coming, and we'll go ahead and get started. I kind of decided on this topic. Last year we had a couple of book signing events. Hopefully a lot of you got to come, and at one of the events in Orlando, Ellen, who helps us organize a lot of these events, came up to me and said, you know, a vet just said to me, what you guys need to tell us is what to say to the clients who diagnosed cancer. And I thought that makes a lot of sense, because it can be a very difficult thing to explain to a client. You know, it makes us as veterinarians feel many different ways about having to give bad news. It's a very difficult thing to do. So I just kind of wanted to cover that topic a little bit. And then as I was thinking about it, at first I thought it was going to be a very small topic, and actually it turned out to be a very big topic. So I kind of threw a bunch of different little sections together to make up this talk, and hopefully it will make sense as we go along. So we'll talk about why is how you discuss cancer important, just some basic definitions about cancer and cancer therapy, breaking the news, how to break the news to clients, just some tips, discussing the diagnosis, what to discuss during treatment, and then, of course, the final stages. So I use as many scientific articles as I could find. There actually is quite a bit of research in human medicine with physicians about breaking bad news and the best ways to do that, and the psychological and emotional effects it has on the physician themselves and on the client, on the patient actually. For veterinary medicine, there's not quite as many, although there are a few. So you'll kind of see as we go along that a lot of this is, some of it talks about the patient, where it really should be our client, you know, if it's physician-based, and a lot of it will talk about our clients because we're veterinarians. And the majority, not the majority, but quite a bit is my opinion. So kind of take it with a grain of salt that a lot of this is just my opinion and my experience going through this for many years. And so first we'll talk about why is how you discuss cancer important. We know that breaking the news is very hard, but the way that it's done has a very heavy influence on then what comes next for the client and for the patient. So in people, obviously bad news, and for veterinary as well, any news that drastically and negatively alters a patient's view of his or her future is considered to be bad news. When you're delivering bad news, what that patient or that client is feeling is often a sense of hopelessness, because they're given choices, very limited choices most of the time. And obviously we strive to give them as many options as possible, but they still are limited to a certain extent. And that's going to involve their mental and physical well-being. And a lot of times in our veterinary patients especially, it's going to be a terminal diagnosis. A lot of cancers are terminal cancers for our pets. And so this complexity can create serious miscommunications, such as the patient or the client misunderstanding the prognosis of the illness or the purpose of the care. So if bad news is communicated badly, it can cause confusion, long-lasting distress, and resentment. And if bad news is communicated well, it can help with understanding, acceptance, and adjustment. So I'll tell you another little disclaimer. A lot of what I'm going to say is what we hear as oncologists, and obviously what I hear, you know, from clients. And you know, when people come, they're already in a stressed state. They're worried about their pet. They're going through a lot of hardship, and they are going through grief. And part of grief is anger. And so sometimes anger comes out directed towards the person who delivered the bad news. And I think that, you know, these statements that I have here came from actually a physician-based paper, and they talk about resentment. And I think that that's actually something that we hear, that clients resent whoever told them the bad news, especially if it was not told in an appropriate way. And so I think it's really important to, if you want to make sure you have a long-lasting relationship with the client, you know, especially in situations where you're giving bad news, saying that in a way that they can understand and will not carry that resentment. If they really understand what's going on, if the bad news is communicated well, they'll accept it a little bit better and adjust more quickly, and that will help everybody to be able to help the patient in a more expedited manner. All right, so the next several slides are just basic definitions. And the reason I put these definitions in there is that they play a little bit into what we're going to talk about later on, but I think they're also very confusing, because whenever we're delivering the news and we're, you know, reading histopath reports to clients or explaining them, and then I know that clients are asking you guys as the primary care veterinarian what what the oncologist is going to say, what are the treatment options, and so it can be very confusing. So I think just sort of making sure we know the vocabulary that we're using and what everything applies to will help in the explanation, and that will help the client understand a little bit better. Hopefully you have been exposed to all of these before, but it's really just a review. So neoplasia just means new abnormal growth of cells. So that is kind of a very broad term, and neoplasm or tumor or growth are really anonymous, and they're just referring to the abnormal growth itself. Benign tumors obviously do not spread. That's the definition. They tend to be tumors that don't grow aggressively and don't invade the surrounding tissue. That's not always true. There's obviously exceptions to every rule, but generally that's the case. And then malignant tumors grow rapidly, invade the tissues around them, and spread. And cancer really only applies to malignant tumors. And the reason I think this is important is because I think it helps when we're talking later about whether a tumor can be cured or not, a cancer can be cured or not. It's important to make sure we know the difference between the two. Clients get all of these words very confused. A client today was telling me that on one paper it said lesion, and on one paper it said tumor, and somebody else is telling her there's a nodule, and they're probably all meaning exactly the same thing, but when we kind of confuse all those terms, we're confusing the clients. So just be a little bit consistent with those terminology. These are all definitions that refer to the patient itself. So the grade is going to tell us how abnormal the cancer cells and tissues look compared to healthy tissues, and grade kind of gives us an idea of the sort of aggressiveness of the tumor, is how I explain it to clients. So in other words, if a cancer is low grade, then it's probably not very aggressive. If a cancer is high grade, then it's likely to be much more aggressive. So the grade really refers specifically to the tumor itself. This stage describes the size of the tumor and how far the cancer has spread in the body. These are two terms that clients confuse all the time. So they come in and say, oh, my vet told me it's a mast cell tumor that's stage 2. And they don't mean stage 2, they mean grade 2. You know, so it's very helpful to make sure they really understand the definition, because then we're going to talk to them about staging, and they need to know what the difference between those is. The margin is the margin of non-tumorous tissue around the tumor, so normal tissue around the outside of the tumor that we look at under the microscope. The mitotic index is something that is becoming more and more important over time. The first cancer I remember really concentrating on mitotic index was mast cell tumor many years ago, but now we know that with many different cancers and tumors, the mitotic index is really helpful in telling us, you know, more about the prognosis for the patient and the best treatment options. The mitotic index is the ratio of number of cells undergoing mitosis to the number of cells not undergoing mitosis. And so in veterinary medicine, the way that they have decided to express this is typically the number of mitotic figures in 10 high power fields under the microscope, or now the number of mitotic figures in 2.37 micrograms squared under the microscope, which is supposedly equivalent to that. hopefully we all know that remission means that currently there's no evidence of cancer, but that there's a real risk that cancer will return. And that cure means that there's currently no evidence of the cancer, but we don't expect it to return. And these are really important terms, and these are going to come up a lot throughout the rest of this talk, just because I think it's important for clients to understand the difference between remission and cure. These words are confused a lot, and I think it's really important to be very specific on, if we're looking for remission, what does that mean? And if we're looking for cure, what does that mean as well? So there are three main different types of cancer therapy. One is surgery. This is the dictionary definition. So surgery is the branch of medical practice that treats injuries, diseases, and deformities by the physical removal, repair, or readjustment of organs and tissues, often involving cutting into the body. So for us, there's a few main types of surgery. One is curative intent surgery. So that means our goal is to cure the patient. So these are typically big surgeries where we're removing the tumor and trying to get a margin of normal tissue around the outside of the tumor. Cytoreductive or debulking surgery really means we're trying to get down to microscopic disease. So we're trying to remove as much of the tumor as we possibly can, hopefully all of the gross tumor that we can see, and leave behind just microscopic tumor cells that are much easier to deal with. Radiation is going to work better, chemo is going to work better if we can get down to those microscopic cells. And then biopsy. So biopsy means we're just getting a sample so we can get a diagnosis a lot of times. Radiation therapy is therapy using ionizing radiation or X-rays, generally provided as part of cancer treatment to control or kill malignant cells, and normally delivered by a linear accelerator. There are other ways to deliver radiation, like you can deliver radiation with an X-ray machine technically, and then there's the older types of radiation where you're actually putting a radioactive little piece of rock near the tumor to deliver the radiation. So those are still utilized some. And there's a few main types of radiation. So one is definitive or full course or curative intent, and those are all kind of about the same type. They're all kind of words that mean the same thing. And that's going to be the typical long course of radiation. So those are the ones that are like, 18 or 20 treatments like the patient had in the video for the bladder cancer that we looked at earlier. And the goal really is curative intent. So the goal of giving that long course of radiation really is to cure the patient, although we know that's not always going to happen. But that's the goal of that type of radiation. Stereotactic radiation therapy is more precisely delivered radiation therapy with the goal of killing as much of the cancer as possible, although not always curative intent. However, the stereotactic radiation therapy is being used more and more and more as curative intent therapy. So, for example, we use it a lot for, Dr. Lyons recommends it a lot for soft tissue sarcomas that are incompletely excised and mast cell tumors that are incompletely excised, so that it is curative intent. Our goal is to get rid of it, but it can be used if there's a big tumor that you can't remove or it's hard to reach, like a brain tumor or a nasal tumor, and this form of radiation is very good for that. Palliative radiation is strictly just trying to make them feel better for as long as possible. Chemotherapy, there are lots of different types of chemotherapy and a lot of different intents of chemotherapy. And these are, I don't necessarily use these words for the clients, but I try to use them to explain like what is our goal of doing this type of treatment. So chemotherapy can be curative intent. So for example, you are have removed a high-grade mast cell tumor, you got all of the tumor out, and you're just worried there's going to be some metastatic disease left somewhere in the patient's body. So we give chemotherapy with the intent of killing any cancer that's left anywhere in the body. So we are trying to cure the patient. Adjuvant chemotherapy is kind of the same as that example that I gave, where it's chemotherapy we're giving after the tumor has been removed in order to try to get rid of any disease that's left. Neoadjuvant means we're giving it before we give or before some other treatment. So for example, sometimes we use it for shrinking tumors prior to surgery, like a mast cell tumor or a fibrosarcoma in a cat. So those are our uses of neoadjuvant. If you're trying to do something to the tumor before you do something else and using chemotherapy. palliative intent chemotherapy and life-extending chemotherapy are kind of similar in that they're just really trying to keep the patient comfortable and extend the patient's good quality of life for as long as possible. So I think of life-extending chemotherapy as like lymphoma chemotherapy, right? So we're really not expecting to cure the patient, but we are expecting to get remission and expecting to extend their life for some period of time. Technically, that's almost like palliative, that for lymphoma, since we're not expecting to cure them, we're trying to make them feel better. So that's almost like palliative chemo. And maintenance chemotherapy, I kind of use for situations where I expect the chemo is just going to kind of hold the cancer at bay. Like we're going to keep it under control for a long time using some sort of chemotherapy that's ongoing. So this is chemotherapy that doesn't really ever end. So for example, like metronomic therapy, where we're giving a little bit of chemo every day for a long period of time. So hopefully those definitions helped. I'm sure you all know the majority of them, but it's always nice to have a little refresher. All right, so how to break the news. So there are several actually papers in physician medicine, and there are consensus statements about how to break the news. So I'm going to kind of go through the consensus of how to break the news in people. So for physicians to break the news to their patients, and then a little bit about how to do the same in veterinary medicine as well. And then I have some tips as far as the major confusions that I see with clients before they come to me in what was explained to them before, or where they just need a little more clarification. So things to kind of keep in mind. All right, so these are the consensus guidelines for physicians to break the news. And I'll kind of go through each of them a little bit, and then you can see where a lot of them are going to apply to veterinary medicine as well, but maybe some of them are not. So the first one is give the news in a quiet, private place. Ensure adequate time at the initial meeting. I know both of these are a little bit difficult to do, actually sometimes a lot difficult to do. I'll tell you, some of our clinics are very busy and very crowded, and so finding a quiet private place can be a challenge sometimes. And obviously we're all very, very busy, and so ensuring adequate time at the initial meeting can be very difficult as well. It is recommended to do these meetings face-to-face, and that can also be difficult because a lot of times we're getting later and having to call clients, but I think actually calling might be okay because it's very quiet and private, and you have the time to give to that client at that time. You want to assess the patient's understanding of what you're telling them. This includes things like preconceived notions about the situation. For example, in oncology, preconceived notions about chemotherapy or radiation therapy, because people have experience with these a lot of times and may already have some understanding of what that is.
Hi, everybody. So clearly we are experiencing a little technical difficulty. So we are going to, I think, just move on and hope that Dr. Sones can just jump right back on. Okay, so I know that he was talking a little bit about consensus guides from the physician, and he was talking a little bit about being in a quiet space, encouraging the patient to sort of express their feelings about what's going on, and giving sort of a broad time frame for the prognosis. I think that that's reasonable, although I find that clients do kind of want some guidance about what is the prognosis. So I do try to do that. So avoiding the notion that nothing can be done. So, not making that hopelessness that the client's already feeling worse, and then discussing the treatment options and trying to explain them. So, a lot of this, understandably, when you're in your practice doing this, some of this is going to be our job. Some of this is going to be our job, and what we do at that first initial consultation. So I'm still kind of hoping that Dr. Sones can jump back in. So let me just see if they're going to want me to continue on. Okay, so it looks like I am continuing on for now. Okay, so so the goal of care are conversations. So appropriate timing. So of course, as veterinarians, we're always talking about cost with our clients, right? So when they're coming to us, I think one of the concerns always is, what is the cost going to be? Are we going to be able to afford this? What are the options going to be? So before we start any kind of treatment therapy or cancer therapy, we're always providing clear and estimates for the clients. And we always try to provide a spectrum of care. So I don't know if any of you read the most recent AVMA journal, but this is what we're really good at as veterinarians, providing a spectrum of care. And that's what we do as well. So there may be a gold standard for CHOP therapy, which for lymphoma, which is CHOP therapy, or there may be other less aggressive, more conservative chemotherapy protocols that we can offer, like single agent adriamycin or lomustine therapy. So we're always trying to give a spectrum of care, and we're trying to provide estimates for all of those things. And the other thing I find is really important is we try to provide the estimates in different ways. So the cost of the whole protocol, or the cost of the whole radiation treatment protocol, as well as how do you pay for that? You know, you're going to pay for that with 50% down, maybe if it's radiation therapy or surgery, or you're going to pay as you go week by week. So appropriate timing, goals of care, and always we're trying to talk about, you know, what is the expected outcome? We want the optimal outcome that's right for each family. So that the optimal outcome is going to be different for each family. So, and also is obviously going to depend upon the type of cancer that we're talking about. So managing the expectations. Okay. All right, so conversation flow. So my dad, many of you know that my dad is retired small animal practitioner. My dad always used to say, you have to allow the client to tell their story. Like, they have to be able to speak. So conversation flow, and that is kind of allowing them to express their feelings, to express their story, where they are. So let them do that, and then you're building a relationship of trust. So then there, of course, there can be these sort of awkward moments, and I find that a pause is okay. Like, it's okay sometimes to pause, to let them collect themselves. Also, the pause allows me to figure out what I'm going to say next, and that's okay when you're breaking these very difficult things. And I try to sort of speak slowly and allow for those pauses.
Okay, thank you. Sorry, everyone. Thanks, Dr. Cray, for taking over for me. All right, so yeah, and then starting the conversation about owner fear. So I think it's okay to say a hope and worry statement by the veterinarian. So say, like, you know, I hope that Fluffy will come through this, but I'm very worried by the diagnosis that we're going to talk about, just so they have some preparation. Ask the owners about their fears and worries about what's happening after you've explained it. And the answers they give you may illuminate some unexpected information, and then also let you know what their understanding is and what their goals are. So, for example, you know, if you say, the client says, well, you know, I really just want him to be comfortable until my son can come home from college for the summer and see him one more time. You know, then our goals change a little bit from, okay, we need to keep this patient alive for years, to we need to just make sure he's comfortable for now until, you know, the family can make peace with everything. And obviously, we always want to approach everything with the intention to be non-judgmental. It's very easy to have some judgment in what we're talking about, especially clients that come in and say, oh, this tumor just grew, overnight, and it's obviously huge, or, this has only been going on for a short time, and obviously it's been going on for a really long time. You also need to be non-judgmental about their response to what you're saying and what their decision is. Obviously it's their pet and their decision, and they're going to make decisions based on what's best for them and for their family, which may not always be the decision we would make or what we agree with, but we have to approach that in a very non-judgmental way. And then starting the conversation about owner fears allows them a chance to deliver, allows you a chance to deliver clear information about the medical realities using a trust-building, sensitive, and compassionate manner, so that they're going to continue to trust you throughout the course of that patient's life, and you'll be able to better help them in making the decisions about their pet. So these are some tips that I think are very helpful, and these again are things that I hear when the clients come in they're very confused about, or that they say, I wish this had happened, or I wish this had happened. So I think it's always helpful to share your suspicion of cancer. I think most of us probably do that, but if a pet comes in and has a tumor or something and you say, we're going to biopsy this, but I am worried that it's going to be some kind of cancer, or, we're going to send your kitty for an ultrasound, but I am worried that we may find something serious like cancer. I think it helps them to start to understand the severity of the situation, but also not be completely shocked when you come back with that diagnosis. And we want to obviously follow the suggested ways to break the news that we talked about, but you have to do what works within your practice and what's practical for you and your staff, and then what's going to work best for each individual client. For the most part, we know them pretty well because they've been coming to you for a while, and hopefully you know them enough to be able to understand their kind of needs in each situation. I think it's good to give the client the exact diagnosis. I can't tell you how many times they come in and they don't know the diagnosis of their pet, or they call to make an appointment with us and they don't know the diagnosis. And I think, it kind of stunts the appointment process a little bit, but it also prevents them from being able to really understand what's going on. I think it's also okay to share the histopath report with them if they want that. Some clients may not want that, but the histopathology report is already written down. The diagnosis is written down. The prognostic factors are there. And a lot of clients are going to Google. And so if they are going to Google and, we don't want to get mad at them for Googling, then we have to give them the tools that they need to Google the correct thing. So if we say, oh, your dog has a splenic tumor, and they're going to go and Google splenic tumors and see everything about hemangiosarcoma, and it really isn't hemangiosarcoma, then that's not really helpful to them. So giving them the tools they need, I think, is helpful. Another thing that I think, these are all things that I think clients get very confused about. So cancer versus not cancer. I think, the reason that that's important is a lot of patients may not have cancer but still get referred to us because they still have a tumor that has to be dealt with. The difference is that a tumor that's not cancer, that is technically benign, can be cured in a lot of cases. And so, it's helpful for them to know that their pet can be cured if it has a benign tumor. However, it still needs to go to the oncologist to be able to treat it. Also, the word inconclusive. A lot of clients come in and say, well, my vet did a biopsy, or we did a cytology, or this and that, and it was inconclusive. And I think that's the correct term because it did not conclude a diagnosis. However, people get frustrated with that term. They say, well, we did all this and it was inconclusive. And a lot of times it did conclude something. So for example, we often get a biopsy or a cytology and it says malignant round cell tumor. Well, a malignant round cell tumor means that the pet has cancer. It just doesn't tell you exactly what kind, but it at least narrowed it down and told you, yes, this pet has cancer. So I think that, using the word inconclusive, I would be a little bit cautious with it because it really frustrates people, so give them as much information as you can, and then just explain, we don't have a definitive diagnosis, but
we've been able to narrow it down, with this information that we have. A lot of clients come in and say, well, my vet removed the tumor and they got it all. But then when we look at the margins, the tumor still has incomplete margins. And so, I think got it all to us means, I got it all the gross disease. I got everything out that I could see and there was nothing left. But microscopically, we didn't. And so I think using that phrase can be confusing because then they think, my vet got it all. And then when I say, well, we still have some microscopic cells, then that's a little bit frustrating for them. And then as we keep talking about cure versus not cure, I think that's really important because, the difference between cure and not cure for some clients is the difference between pursuing treatment and not pursuing treatment. There's lots of reasons where it may be difficult for them financially or time constraints or whatnot. And if their pet's going to be cured, they'll go through that hardship. And if their pet is not, then they're not going to do that. So if you have any way to tell them, I think your pet will be cured or not, then I think that's helpful to them. Again, when they're deciding whether they should be referred or they want to be referred, then cure versus not cure is very important. Also knowing that the costs are very variable. Cancer therapy is not inexpensive, but it is attainable for a lot of people. I think sometimes more attainable than we realize. And so, explaining to them that the costs are very variable, the time commitment is very variable, but it's worth pursuing to find out that information. And then there's many different treatment courses. We can choose different treatments based on each individual patient and client and what's going to work best for them. And I think the last thing, and I'm sure you all know this, but it's always okay to say that you don't have to treat. Like, it's always okay not to treat a pet for cancer, especially when it's cancer that's not curable and it is going to be terminal for them. For a lot of people, again, it's a lot of hardship to go through, and they don't want to go through that if their pet is not going to be cured, and I think that's perfectly okay. And we often will give that as an option as well. All right, so a little bit about what we say to clients once they come to us. I found this one study, and this is very wordy, but I think it's hilarious because it was a qualitative study of the communication expectations of clients accessing oncology care at a tertiary referral center for dogs with life-limiting cancer. So the clients expected the information to be communicated in a forthright manner in multiple formats with understandable language in an unrushed environment wherein staff took the time to listen, answer all questions, and repeat information when necessary on a continuous basis with 24-hour access to address questions or concerns in a timely manner with positivity, with compassion and empathy, with a non-judgmental attitude, and through staff with whom they had established relationships. So I think it's so funny that this is such a long expectation, but really it makes sense, right? I would expect all of these things as well. They're going to someone who is supposed to be the expert and supposed to help them and help them make decisions, and they need all the information they can get in the way that they can understand it, and they don't want to be rushed, and they want to make sure everyone's taking their time to take care of their pet. So I think this is what they expect, and this is what we try to give them. And it is attainable, to be honest with you. It really is. So what we do at our consultation is explain the tumor type and the behavior of that tumor. We generally will go over the key points of the biopsy report, especially if the client's interested. Some are not interested, and we'll skip that section, but some are really wanting to understand a little bit more detail, so we'll go through that report. So again, it's helpful if they've had it before, because then they've already read through it. We'll review the diagnoses that have already been done, discuss the diagnostics we think may be helpful going forward, and then talk about the prognosis. And these are I know I said this a million times already, cure versus not cure, but these 2 points, cure versus not cure and intent to treat, were the two, I think, mind-shattering things that I learned in my residency. Because I remember the moment that I learned both of these things, that it was actually a internal medicine clinician that told me you should always tell the client if the pet is going to be cured or not cured. And then the oncology clinicians I would say, okay, this is my plan. And they would say, what is your intention of that plan? What is your intention to do that treatment? And I think those two things are really important for clients to understand. We are doing this treatment, or we are recommending this treatment because our intention of that treatment is to do something. And that intention may be to cure the pet. That intention may be to not cure the pet, but make them feel better. Our intention may be to cure their pain for a while. And so I think helping the clients understand what's the reason we're doing this and what's the long-term outcome of that is really important. We're going to make the treatment plan, and we're going to take into account the patient, client, and cancer factors. So, you know, the patient. So are they comfortable coming to the clinic? Do we need to pick something where they don't have to come as frequently? Do we need to pick a treatment where they're not handled as much? Do we need to think about giving them some medication to calm them before they come? The client, what are their abilities? What are their emotional abilities? What are their financial abilities? What are their time constraints? You know, what can we take into account to make the treatment as easy on them as possible? And then obviously the cancer, we want to do all of those things, but we don't want to pick something that's not going to work just because we don't want to touch the dog and the client can only come once a month, you know? So we're still going to keep in mind that we're going to pick something that works best for the family, but also that's effective for the cancer. And then we do give a written summary of their visit, just as is expected in that study that was done. So during and after the treatment, we're obviously in a huge partnership with you guys as the primary care veterinarians. You know, the patients are expected to continue preventative and maintenance care because we hope that they're going to live a long time and still need that. We often will need your help managing the adverse events. You know, the cancer therapy is not without side effects, and sometimes those side effects are going to happen, and the pets may need care for that. And then the primary care veterinarian is often the patient and client advocate. You guys have known them a lot of times for a lot longer than us, and know them very well and know the patients and clients very well and can speak for what is going to be helpful for them. A lot of clients come to us and then say, you know what, I'm going to go back and talk to my primary care vet, and then I'll call and let you know my decision after that. And so, and I totally respect that. You know, you have been part of their life for a much longer time than us, and I think that's important to honor that relationship. We're always going to have a continuous discussion of the patient's quality of life throughout the treatment. Quality of life is our #1 goal for all oncology patients. Our treatment success, is the treatment working or not? You know, is our intention being fulfilled? You know, is the cure there or is the cure not there? Do we need to alter the treatment plan based on the treatment success? And then also recurrence and metastasis are big things that we're looking for, and we're going to have a continuous discussion. And you know, when do we expect that to happen? Has it happened yet? What is that going to influence? How is that going to change our plan? And then, of course, the end stages. So, again, constant assessment of quality of life of the patient. If the quality of life is decreased, can it be improved? And if so, how and for how long? And if the quality of life is low and cannot be improved, then it's time for palliative care, hospice care, or euthanasia. Those are, again, conversations where you as the primary care veterinarian are often a big part of that decision process, and you've known those patients and clients a lot longer and can help us in deciding, you know, when that time comes, because it comes a lot, unfortunately. And with that, I'll take any questions.
Thank you, Dr. Sones. I mean, really, what an important topic that you're covering for us tonight. And I know there's a lot to this. There's a lot to this, and thank you, because you kind of broke it down for us. And there are a couple of questions. So the first thing kind of goes back to the word cure. I mean, do you use the word cure when you're talking to clients?
For me, it's pretty rare. So that it has to be something where there's a really high chance of a cure. So for example, like a low-grade mast cell tumor that was removed from the side of the thorax and had a huge margin and a low mitotic index, those ones I'll say, you know what, your dog was probably cured by this surgery. Or, you know, another example is like a acanthomatous ameloblastoma that we can remove, you know, and get a good margin and it's gone. That's probably a cure. But most of the time, honestly, I'm saying, you know what, we're really just not going to be able to cure your pet. And I think that's the reality of veterinary oncology compared to human oncology, is that we don't cure as much as we would like to for many different reasons. But I think that's important for people to know.
Yeah, I mean, I definitely agree. I try not to use that word very often. And I also find, and I want to ask you this, do you feel like people think that remission and cure mean the same thing?
Definitely. They do mean that. They think that a lot. And so I've learned over the years to say, you know, especially with dogs with lymphoma, because that's what we're always talking about is remission. I say, oh, he's in remission for now. You know what I mean? Like things like that. And they say, oh, he's in remission. That's great. And I say, and let's just see how long it lasts, you know, and I'm not trying to like be negative or anything, but you know, it's important, I think, for them to remember that they're not the same thing, and you know, that sort of thing. So yeah, I think that is a very confusing, two confusing terms for sure.
Yeah, I agree. And sometimes I'll even say to people, look, if he's in remission for 5 years, then maybe we'll think he's cured. So
Right.
kind of do it from that time frame. So
Yeah.
and then another question.
One of my old, oh sorry, before you move on, one of my old mentors, he's not old, one of my previous mentors, he used to say that we should use the term apparently cured for veterinary patients because, you know, if you, like you said, if you go 2 years and it doesn't come back, then you can say he's apparently cured from it. Or if it's a very old dog and they're going to pass away before you think the cancer is going to come back, then they can probably be cured because it's not going to come back in that patient's lifetime. So maybe that's a more appropriate term, but I think that he used to say that a lot, but I think that confuses clients a little bit more. But I think for us, it gets the point across that apparently he's cured, although it's always a little bit hard to believe.
Yeah, time will tell. Time will tell, I think. Right. So we do have another question. If a client asks you what you would do if it were your dog, would you give an answer or do you defer and tell them that you can't answer that for the client?
You know what? I answer. And it's funny because a lot of clients say, I know this is not a fair question, or I know you probably won't answer this question. That's always their like preamble to saying that, but I answer it, and I answer it not, I don't want to say not truthfully because it is truthful, but I take into account what I would do and what I think they should do based on the information that they've given to me. And a lot of times I will say too, keep this in mind, just because I would do that doesn't mean you have to do that. And also I'm in a very different situation than you. You know what I mean? And they seem to understand that. Like, so I do answer it. I know a lot of people don't, and I respect that 100%, but I do answer the question.
I do as well. I answer the question. And I'll also say to them, hey, I would never recommend something for you that I would not do in my own dog. And that's the truth. Like if I'm not going to do it in my own dog, I'm not going to tell the client to do it. So, I do too. I do as well. I feel like we're building a relationship, and if they ask the question, then I'm going to answer. Mm-hmm. Okay. So we've also got, the way that you use the term, and I love this, life extending chemotherapy. Can you speak to that a little bit? Because I feel like that's really what we do like all the time.
Yeah, exactly. I learned that term a few years ago I was reading in a physician-based article. I don't know what to call them, human articles or whatever. And they used that term, and it kind of was like a light bulb in my head, because that's really, like you said, that's what we're doing the majority of the time, is we're giving them life extending chemotherapy. So with the descriptor that it's good quality of life extending chemotherapy. Again, we're not going to cure most of them. We're just giving them chemotherapy to keep the cancer under control, keep the patient's quality of life as good as it can be, and help them to live longer, you know? So I think that term is really descriptive in giving people an idea of what's going to happen, and it kind of takes away that idea of cure without you having to say it over and over again. It's like, okay, we're giving life-extending chemotherapy because that means we're extending their life. It doesn't necessarily mean forever, you know, but it is, I think, a helpful term to use.
I agree, and I think people come and they have these preconceived fears about chemotherapy, like it's going to make their dog so sick and it's going to be terrible. And when you say, actually, no, the chemotherapy is going to make him feel better and then extend his life, I think it's just, I like your term, palliative or life extending chemo, because it's really helpful to explain that.
Yeah.
Okay, let's see. What else do we have here? Okay, so you had talked a little bit about breaking the news on the telephone. And I think this is really helpful for our primary care veterinarians, because I feel like a lot of times they're doing surgery or a biopsy or whatever, and then you guys have to call the client and talk with them on the telephone. And that's what I hear all the time in the consult. The client comes in and they say, oh yes, my veterinarian called me and gave me the diagnosis. So can you speak to the telephone a little bit? Because for me anyway, it's hard. Sometimes it's hard to do it on the telephone.
Yeah, I actually don't like to do it on the telephone, to be honest with you, but I think it's the reality of our situation, because if you're a person, right, and you get a biopsy or a big test like an MRI or something, then you schedule a recheck and you go into your doctor's office and you get the answer there. And we don't tend to do that in veterinary medicine as much as it's done in human medicine. And I think it's just a practical thing. You know, people don't want to take off of work and come back in and make another appointment. And then, you know, from a business standpoint, are you going to charge them another exam fee to come in and take up an appointment spot in that? And so we call them. And that, I think, was one of the biggest differences when I was reading about human medicine versus or how to break the news for physicians, was that they often actually repeated over and over that it should be done in person as opposed to over the phone. But I think for us, it's done over the phone, and I think it's expected by the clients to be done over the phone. And so I don't think it's as big a shock to them when we do it over the phone. However, I agree with what you say, because we have to give bad news sometimes. And I find it very difficult to do that over the phone, because so much of the interaction is body language and seeing the person's expression, and you can read on their face if they're understanding what you're saying or not. And you lose that a lot with a phone call, you know. So, I mean, I guess it's fair to ask people, do you want to come back in for the news or do you want me to call you? But I don't know that we all necessarily have the time to do that, you know. But I agree, it's very difficult.
Yeah, it's difficult. And I think for me, depending on the client, I'll have them come back in, because sometimes,
Yeah,
you just have to. All right.
yeah.
So, okay, so here's one that we all as veterinarians, right, like we're all dealing with the cost. So the question is, how do you justify the cost to clients? And I think maybe even how to say that, like, how do you tell the clients the value in that and what you're doing?
That's a very good question. And one of the articles I read was discussing cost, and they looked at they videotaped conversations between vets and clients and looked at how often the cost came into the discussion and how was it, what was it pertaining to, you know? And the point of the article was exactly what you're saying, is that when we discuss cost, we should be discussing the value of what they're getting for the price that they're paying. And the reality was, in that study that they did, it only happened about 14% of the time, that when cost came up as part of the discussion point, that it was related to the value of what they're getting, only a very small percent of the time. I think the way that I do it is not so point blank, like this is what you're getting for this amount of money. It's more like, okay, so we can do radiation, and this is how it's going to help your pet. It will improve the quality of life. We will get this amount of time of, disease-free interval, and we can do it in these different ways. And maybe this way is a little more costly. However, it will spare the normal tissues, and then they'll have less side effects and kind of that. And the same with chemo, okay, it's an ongoing cost, but it's going to give you this much time with your pet. Their quality of life will be improved. The side effects are minimal, those sorts of things. And I have to say, I don't get a lot of pushback on the cost. And maybe it's because you guys as the primary vets do such a good job of preparing them, before they come, that, that it's going to be costly. But I think the way that I justify it is more discussing, what are we going to get out of it, more out of the treatment more than the specific cost itself, I guess. I don't know if I'm answering how you.
No, that's perfect. Like you're talking about what is the expectation? Like, and sometimes I'll just break it down, like you're saying. Like I'll say, okay, we are probably going to spend X number of dollars, and the average remission time is a year. So if we just look at the middle, you're going to spend X number of dollars, and he should be well for another year. I try to break it down like that for people.
Mm-hmm. Mm-hmm.
It's hard though. I mean, it's definitely hard.
And I think that the value too is different for everybody, right? Because some people might say, well, that 1 year is not worth that much money to me, and I respect that, of course. But I think it's going to be different for everybody what they perceive as the value for their money, of course.
Yeah, of course. And I think this whole idea of spectrum of care is, I mean, veterinarians, we've always done this. Like, this is what we do. We present options of care for people. People want to feel like they're doing something, they're doing something for their pet. So I think we're really good at that. Let's see. I think we have maybe just a few minutes. So we'll do one more. Here's one. Okay, this is a good one. Prognosis. What, like, do you give a prognosis? How do you give a prognosis? I think that people want to know, and that can be hard sometimes in certain tumors. Like, we might not even really know for sure. So what do you do?
Right. Well, yeah, I mean, I think one part of the prognosis is the cure versus not cure, right? So that's always the first thing to establish with prognosis. And then the next is, it's changed over the years how I presented it. So, when you first come out of your residency, it's like, all these numbers, right? Every median survival time for this and every response rate and all that. So you kind of spout all those things at people. And then after a little while, you realize they don't understand that very well. And that's, understandable. But then it started. So the way I kind of do it now is it's more like a range. Like, okay, we're going to cure or not cure, and we're probably going to get this much time, like 6 to 9 months, or sometimes 6 months to a year, or it's like a year to 2 years. It's a big range that I feel comfortable based on my experience that it's going to fall into that range pretty well. But sometimes I pull out the whole, like, I can give you statistics all day, but for your pet, it's 0% or 100%. Like, it's going to work or it's not. And what we have to decide is it worth trying or not, based on everything that we know at this point. So, I mean, prognosis is very tricky, especially when it's something big like cancer where they're going to pass away. It's like, when is that going to happen? I don't know, but I can give you a pretty good idea.
Yeah, I agree. People really want it to be exact, and we can give them a range, and sometimes we can get really close, like you said, like 6 to 9 months. Like, we can get really close, and sometimes we can't. So it is tricky. I had a client that was a medical oncologist on the human side, and he told me, hey, after you've been practicing for about 35 years, you'll literally be able to get it down to the month, like how many months, So I always think about that, like, maybe sometime I'm really going to be able to do that. So we'll see.
I'm definitely not there yet, for sure.
Yeah. All right. So I think I don't see any more questions. So I think I'm going to go ahead and wrap things up. Thank you so much. What a valuable lecture you gave us, and so much really good information. And thank you to all the veterinarians for being here tonight. I really appreciate the support, like I said. And I can't wait to see you all for our next summer webinar series. So look for the invites, and we will see you then. Thank you so much, everybody.